Hi everyone, welcome to today's webinar on optimizing your pharmaceutical waste program. My name is James and I'll be your moderator for today's event. Before getting started, I'd like to give you a brief overview on what this webinar is going to entail. So we'll start things off with a slideshow presentation addressing considerations for program implementation if rolling out a new pharmacy program, as well as some useful advice for maintaining and improving your current program. You will also get the chance to hear a few case studies from our speaker and hear from his experience working on various pharmacy programs. I'll let him go into more detail with the agenda. Following the presentation, there will be an open question and answer period. You can ask questions anytime by typing them into the chat pane or the questions pane on the right-hand side of your screen. Please note that everyone's microphones will be turned off for the entirety of the webinar, but if you have a question or a technical issue comes up, once again, you can use that questions box to communicate. Please keep in mind, you will receive a copy of the slide deck and the presentation recording tomorrow, so all the materials that are presented today will be sent to you tomorrow, so no worries there. Today's speaker, Dennis Carroll, is Healthcare Operations Manager at Triumvirate Environmental, where he is responsible for managing and improving his clients' hazardous waste programs, as well as being available for emergency response. He has played an active role in pharmacy program development and is eager to share his thoughts and experience with you today. And with that, I will turn things over to Dennis. Hey, Dennis.
Thanks, James. As James mentioned, my name is Dennis. I work with Triumvirate in the healthcare niche as the operations manager. I've been working with Triumvirate for about close to 5 years with a good focus of most of it being in healthcare. Some of my background, I started out as an environmental specialist. I did that for 2.5 years and then was promoted shortly after. But we'll actually jump right in and get started. So one of the key messages we wanted to send across today was really getting an understanding of the importance of reviewing and reevaluating your pharmacy program on an annual basis. And we'll go into a little bit more detail. So there is a few target audiences that we wanted to point out what this training was really entailed for. So specifically environmental health and safety, environmental services, and facility management, or really anyone else that is responsible for managing their pharmacy waste program and keeping track of all that is to go with it. So we wanted to open up with a quick poll question. And we'll give you a couple of minutes to answer, and we can kind of review after. But the question is when is the last time you have characterized your formulary?
All right, Dennis, we've got the results here. About 50% said within the last year, another 36% 3+ years ago, down around 10 to 15%. It's been about 2 years. So there you go.
So that's actually that's pretty good. We'll go into a little bit more detail as we go, but typically we would recommend that people are checking and reevaluating their formulary on an annual basis. So thanks everyone for answering. It's super helpful. But we'll continue to move on through this. So what you might be thinking is essentially, what will I get out of this training? So what you'll learn, so we'll start out with pre-program implementation, specifically how to plan and strategize on the front end of rolling out your program to have a successful implementation and sustainable program. Also, the ongoing program management, how to maintain and continuously improve your program. And then also we'll cover the importance of reviewing your program on an annual basis, which we've discussed. And this includes the recharacterizing of your pharmacy program, and also addressing any updates and concerns that come up with that process. And then ultimately how to successfully manage a sustainable pharmacy program long term. So the first section being pre-program implementation. So a lot of things to consider before introducing the pharmacy program is, as we discussed, the formulary characterization process. Another area is considering generator status as you set up and strategize your program, specific waste streams to consider aside from your hazardous waste medications, and understanding all roles and responsibilities within the program, and then coming up with and creating an effective plan to initially roll out. So we'll go into a little bit more detail. So many of you on the webinar are, my guess, are very familiar with how the formulary is, how it's set up. So typically it's set up in an NDC number, brand name, generic name, and form, whether or not it's in pill form or if it's in a liquid form. Just that breakout in general makes up the makeup of a formulary. And then the actual characterization process. So the characterization process is really beneficial for a lot of different reasons. By characterizing, it narrows down all the medications that you have in your program, which ones are hazardous per the state and federal regulations, and it gives you an ultimate idea of how you need to set up your program and what different waste streams that you need to characterize and set up along the way. Tells you which medications are compatible or incompatible and what needs to be separated from most of the other meds. It also gives you size and type of containers that you'll need to use based on how much of this waste you're going to be generating, and then it also helps you set up your labels and signage throughout the program and throughout the hospital. Another thing to consider that helps with the formulary characterization process is your ultimate end disposal requirements. So what we get out of those formularies is what dictates is how the profile is getting made up. So which waste codes are getting sent for disposal, and that essentially tells the end disposal facility how these items need to be handled in a compliant, clean manner. Another thing to think about is your generator status. You know, really consider right on the front end are you properly registered for the materials that you're going to be generating out of your hospital. Also, things to consider is your state requirements. So the example being one is P-listed material, and for conditionally exempt small quantity generators and small quantity generators, you have a limit of 2.2 pounds, and typically that's pretty hard. It can be pretty hard to maintain and track as a small quantity generator. But another example I wanted to kind of throw out there was, I know a lot of listeners are probably from the Massachusetts area, so I did want to mention VSQGs, the very small quantity generators on the Mass state level, and those cannot generate any P-listed waste. So this is just outlining the importance of considering your generator status, not only at a federal level, but at your state level, and knowing which waste streams and which types of waste that you can generate on a given basis. Another section I wanted to talk about is specific waste streams that can come up throughout the process. Now, the four I have listed here are non-hazardous waste, narcotic waste, NIOSH listed waste, and bulk and trace chemotherapy waste. And I wanted to kind of go through each one of those in a little bit of detail and go through their importance of outlining. So one of the more typical and what makes up most of pharmacy waste in general is your non-hazardous waste. And a common question that often gets forgotten in the beginning stages of setting up the program is, where does this material go? The setup of a program typically outlines how you're collecting hazardous waste and where that ultimately needs to go as far as a container or a bin or however you're going to collect it. But what you really need to consider, and will avoid a lot of confusion on the nursing front, is how are you going to collect your non-hazardous waste. Extremely important to outline that right at the beginning. Let them know exactly how those items need to be collected. Are they going to be collected in a hazardous waste container? The biggest problem with that, as you see, is typically small quantity generators have a hard time doing that because they have to stay under those minimal requirements. So lumping your non-hazardous waste in with your hazardous waste could lead to generator status issues. In some cases, we have scenarios that people have an entirely different collection container for non-hazardous waste. The biggest piece out of this is just clearly articulating in your procedure and program how you're going to manage this waste, regardless of how you're going to do it, just to avoid any further confusion with any of the end users. The second waste that I wanted to discuss was narcotic waste, and the question more times than not that you're going to get is, can narcotic waste be disposed of in the pharmacy bin? There's a couple different ways of looking at that. On a EPA or state level regulatory body, it's not a huge deal. I mean, there's no waste codes being generated in the narcotic waste, but you have to really think about what your DEA requirements are. And in this situation, the DEA requires that this material is not retrievable when you're wasting it. So it's very, very important that you're considering that, whereas throwing it into a pharmacy bin, it is at that point still technically retrievable. So just clearly, again, the importance of just clearly articulating how that process is going to look. It's going to save confusion on the back end, having it clearly written right into your procedure. And the biggest piece of that is just training on it. I know what a lot of you guys are familiar with is the witness wasting procedure. So the witness wasting procedure is pretty common and pretty much the same throughout. It's just that end piece of how that material is getting wasted. The third one was NIOSH listed wastes. NIOSH listed wastes aren't typically hazardous. Some of them could contain a RCRA code, but typically not. A lot of them do not carry any sort of code at all. So a lot of the times what happens is nurses get confusion because they see this as a hazardous waste. It's something that could have health issues down the line. So they want to know exactly how that stuff's going to be handled. And in most typical cases, we have it collected in a hazardous waste container. But at the same time, like non-hazardous waste, you really have to consider your generator status when setting that type of program up. It is something that can be collected in a non-haz container as well. And then bulk and trace chemo. Sorry, everyone. Bulk and trace chemotherapy waste. So in most cases, there's bulk chemotherapy waste, which in most cases generators do collect in a black bin, only because there are bulk chemotherapy wastes that do contain RCRA codes. A good example of this is the mitomycin C. It is U-coded, so it is something that should be collected. But the trace chemotherapy is something that typically comes into question, and there is another layer of confusion as to how this stuff needs to be collected, because now you have a black bin set up and you have a yellow bin set up. Which one are you supposed to put what in? So just, again, I'll go back to just making sure that in the procedure and in the training, when delivering this training, that we clearly articulate how these items need to be disposed of. Another important aspect of the implementation portion is identifying roles and responsibilities. And the three specific roles and responsibilities, the users that come into mind are nursing, pharmacy, and EVS or housekeeping. So it's really important when completing the implementation portion of this is getting these parties involved early and getting their buy-in to the process and almost allowing them to feel like they were a part of the process to, at this point it'll help you with a smoother operation, less pushback when you're rolling out the program, but ultimately a better understanding of the program as you're rolling it out. It's nice to be able to trust the fact that you're going to have a DEP inspector that could potentially come in, and that everybody that has any part of this pharmacy program is educated on the program and understand their roles in the program. And another part of this is making sure you hear their concerns and feedback. And I'll start out with nursing, who's ultimately the largest end user of this program, and ultimately just allowing them to stress their concerns and stress what their thoughts are right on the front end is going to help you on the back end as this program gets rolled out, because again, they'll have that feeling of buy-in, and they'll have an understanding of what the bigger picture of the program entails. They can also help with program functionality, what's going to work best for where, and then even small things like container location. That's probably one of the biggest pushbacks you're going to get in a pharmacy program implementation rollout is my container's in the wrong spot. We have to move the container. It's really important of those little concerns that how big of a benefit it can be to get these people involved. And then I also wanted to talk about the pharmacy, and their question is going to be, what is my role? And from hospital to hospital, it may vary quite a bit. In some cases, they might be the party that's actually managing the whole pharmacy program in general. But regardless of what their actual role is, it's really important at the beginning to articulate and clearly outline what their role is going to be, and again, to help on the back end of the actual rollout process. And then EVS and housekeeping management. They're going to ask the same thing, what is my role? And typically, EVS and housekeeping, they're your feet on the ground. If there's a container that needs to be picked up, they'll be the ones that will probably pick it up if you don't have a vendor on site. Typically, there is a vendor on site, but if the vendor is not on site, they're the ones that are assisting with the actual pickups and all that good stuff. So their biggest concerns are going to be around safety. They don't have a whole lot of education on what are in these containers, what hazards am I being exposed to, and just the overall material handling. And at a training standpoint, it's extremely important that we're catering all of our trainings, specific trainings as we roll out the program, to each department. So training on what their role is, and I don't know how useful it would be for EVS to get a training on what's supposed to go in what container, because they're not responsible for really making those decisions. They're more responsible for, okay, how do I safely and compliantly get this container from A to B, and that's why I just wanted to stress the importance of the training piece, and ultimately on the nursing end too is just getting nurse education involved really early as well. They're going to have a really good understanding of how the actual training and all of that outlook should look like. And we'll go in a little bit more detail with training, but I just wanted to throw that out there. But part of the initial training is, again, like I said before, is being department specific and deciding what type of training you want to give in your hospital, whether it's going to be something that you're going to do something formal, or is it going to be an in-service training. Formal being, the front of the class, PowerPoint presentation, and the nurses come to you. Whereas you can do in-service trainings where you're actually going out to the floors and getting them in their environment and training them there. Now, the key thing with both types of trainings is they both have their pros and cons. Formal trainings are great because you have all of their attention, and they're not going to have any distraction other than what's in front of the class. And so you're going to have their attention, but on the other end, you're not really keep putting them in their environment and physically showing them where the containers are going to be located, how the containers operate. So typically there is some confusion there. And then kind of the vice versa with in-service trainings. In-service trainings, you get them in their environment, and you can physically show them where everything's going to be located, how everything operates. But at the same point, it's, and rightfully so, they're going to be very distracted because they have patients that they're tending to. So obviously at that point, the patient's going to come first. So like I said, there are pros and cons. It's just figuring out what's going to work best for your facility. And then what's the plan for training future new hires and actual orientation training? So this is something that typically, one or two slides get thrown into the actual orientation training that helps them get educated on what the actual program is. But how is that followed up on, and how is that followed through to make sure people understand what's going on? And then once you get a pretty slick handle of all of those items, you should be all set to roll out the program. And again, just making sure you're doing a lot of the planning and strategizing on the front end and coming up with a strategic plan to execute the actual rollout. So that's the end of that section. As James said, there is questions that can be asked. Just make sure you write it in the pane, and we can kind of address any of those right at the end. But as we move on, I'm going to jump right into optimizing your pharmaceutical waste program. And then I wanted to throw this key message out there because this is really where it's going to come into light, is understanding, again, the importance of reviewing and reevaluating your pharmacy program on an annual basis. So the things that are going to be covered here is assessing your program, how your program is operating, understanding the importance of an annual evaluation of the program, how you're conducting ongoing SAA inspections and compliance inspections, and what are the benefits to those. And then something I wanted to share I have personal experience with is an actual container sampling that we have used as a method of evaluation of the program. And then overall continued training and how you're utilizing the resources that you have at your disposal to train and educate the nurses on an ongoing and frequent basis. So we'll jump right in, and this is the point where you really want to assess how the program is operating. And this can be done in many different forms. You know, in some cases, hospitals will use surveys and questionnaires just to get, you know, a lot of the nursing staff, the EVS staff, the pharmacy staff, to get their insight on how everything seems to be running, what improvements can be made, and, you know, just making sure that you're considering all feedback, whether it is good, if it's good or bad. You know, then at that point, also reviewing your inspection data. At that point, what improvements can be made, what things don't need to be changed, what's working, what's not working. Is the program sustainable? Is it set up in a manner that's it's going to last a long time and be compliant for a long time? And then, are you staying within your regulatory limits, which is obviously extremely important when you're doing these reevaluations. So, again, understanding the importance of annual evaluation of the program. So the one thing to really think about is the fact that your hospital's formulary could be in a constant state of change. So as things are changing, more medications are being added, some are being dropped, which could completely change the makeup of the actual formulary and what's being collected and what needs to be updated and educated at a nursing staff or any of the end users standpoint. So the formulary characterization process, and again, you asked the question: have hazardous medications been added or removed from the formulary? Does your formulary still align with your generator status? And looking at P-listed, and again, this is extremely important for the small quantity and conditionally exempt small quantity generators. Is how much P-listed waste am I generating, and how am I tracking it? And is there a method of tracking that's actually happening? And do we know for certain that we're staying within those limits? And is it being noted on the manifest? Little things like that. And then ultimate waste disposal, again, like we talked about before, is knowing whether or not the waste profile needs to be updated. If medications are being added, how do you know if they're hazardous or not without doing that characterization process? And the same goes for if anything gets dropped. There's specific waste codes that could be coming off that formulary as well. So it's important on the waste disposal end that the end facility is receiving an up-to-date profile that tells them exactly how to dispose of the material. And then also there could be potential compliance issues with not consistently reviewing your program. So one thing that happens pretty consistently is nurse confusion around specific medications. So if medications are being added to the formulary, nurses are probably going to see that. They're going to know that they're using new medications, and then there's going to be confusion if not addressed how that stuff is supposed to be disposed of. And you know, when you get to the point where nurses are making decisions on their own, you know, really at that point probably uneducated decisions based on the RCRA regulations that they're probably not well versed in. That's when you come to problems whether or not things are getting disposed of properly. And then there's the chemical compatibility part. So if there's, say if there's a situation where silver nitrate is not part of your formulary, and then you start using silver nitrate sticks, how is that getting disposed of? And did we find that in the formulary when we reviewed it, and how is it getting disposed of? Do we need to create another waste stream for that so it's not getting lumped in with the catch-all bin that's collecting isopropyl alcohol? So there's the compatibility piece that we need to really think about when collecting the waste as well. Unaccounted waste codes that we talked about on the waste disposable end, but also improper labeling. So typically pharmacy waste containers have fixed labels that have, based off the formulary characterization, what's on the labels based off that formulary characterization, what's hazardous. So if there's medications that are being thrown in there that are not on that label, it's technically not compliant to the labeling requirements that for the EPA and state regulations. And then also, the ongoing satellite inspections. This is a huge thing as far as the maintaining of your program and how things work effectively and how you ensure that things are being run compliantly. And so, I mean, how often, asking the question, how often are these areas being inspected by somebody who's trained to check these areas, whether it's a vendor or somebody internally? Is it on a weekly basis, a monthly? Is it never? So things to consider based off what you get as results and feedback, from the actual staff. Just another thing to consider. And then, documenting inspections. Document inspections, and specifically, this offers another way to trend data. Is your program compliant? Is the right things being disposed of in your containers? Are containers properly labeled at this right time? Are containers being pulled within that 3-day FILMAR, 3-day window when full? And again, it reassures compliance and it's best management. When the EPA or a state regulatory body walks in to survey and inspect the program, they're going to like to see documented inspections to tell you're showing proactive ways to improve compliance around the subject. And then another great feature is, in some cases you can do a lot electronic inspections, whether it's on an iPad or some sort of technological device that allows you to have data pretty easily. So being able to collect data and run trending reports and run all sorts of reports that can tell you exactly where things are, where you're having issues as far as compliance goes. Is it the 3-day rule? Is it compatibility rule? Is it labeling? And it can really help you target where things are going and how things are being disposed of to help you later on using that data to help train your staff on where you're struggling in the program. And then obviously being able to run these graphs and show a regulator how you're managing this program is another huge benefit. Another thing that we've actually started doing is actually doing physical container sampling, where you can break down pharmaceutical bins to see what exactly is going in there. Really making the determination or all forms of your waste being collected appropriately. And I'm sure all of you are well aware that you'll find biological waste in there, biological sharps waste in there, trace to bulk chemotherapy waste that might not supposed to be going in there. In some cases I found trash, things like spoons, food products, ketchup packets, forks, knives, anything like that could be getting collected, because in one of those nurse areas there's so many containers for disposal, and sometimes it's just whatever one's easiest is the right one in their mind. So I wanted to show you some data that we also pulled from one of those actual container samples. So again, this was opening up several containers throughout the facility and really segregating out how and what things were actually compliant versus what wasn't. And again, anything like this, if you were to do this on your own, make sure you have the proper personal protective equipment in place to do this, because again, you can find sharps and needles in here. So, making sure that that's all, that you're being safe around it. But more interestingly is going through this data. So roughly 24 to 25% of the waste was actually compliant and what was supposed to go into the containers. And pretty predictably, you can see that most of the waste that was being disposed was non-hazardous waste. Non-hazardous waste makes up most of pharmacy waste, so it's not surprising. But again, as a small quantity generator, is that where you want your non-hazardous waste going? That's adding weight to what is a hazardous waste container. So again, what could potentially affect your generator status is items that don't need to be collected as hazardous waste. And then we've even seen universal waste. We pulled out lithium tabs, lithium-ion tabs, alkaline batteries, lead-acid batteries, and even in some cases light bulbs, broken light bulbs. So it's just another thing that, opening these things up and seeing what's actually being wasted and getting an understanding of what actually is being wasted. And then you can see biological waste is pretty common to find in these bins, which is also a concern. In this case, in this facility, it wasn't a huge issue. I would say 4% is pretty good in comparison to others. And then 14% of the hazardous waste you're shipping out was actually just trash that could be going into a municipal trash can. So again, your food products, articles, your spoons, forks, anything that doesn't need to be collected as anything, just normal municipal trash is being collected as hazardous waste, and you're not only potentially affecting your generator status, but you're spending, that's a lot of money to dispose of normal trash as hazardous waste. So just something I wanted to share with you. It's something that I've done personally, and it yielded some pretty cool data to see what was actually in those containers. And then the ongoing training plan, and really using those resources. So we talked about using inspections, and we talked about using sampling data, the actual container sample that I just showed you, the direct and indirect feedback, taking all of that stuff and taking into consideration and using it all as a means of training, and putting that data together and creating updated trainings to really cover the stuff that your hospital is struggling with, but also not just the items that the hospital is struggling with, but more so the stuff that had updates based off the formulary characterization. So there's tons of ways to collect useful data to use as training that could sit pretty good with a lot of nursing staff, pharmacists, and your EVS staff, to give them a good idea of what is happening, what actually needs to happen, and then coming up with a decision on how often these trainings need to occur. Now I know one thing that's pretty common in most facilities is for nursing is something like a skills day. That typically happens once a year, twice a year, however often your facility's doing it. But coming up with a separate booth for skills day to kind of really go over and cover a lot of the stuff and make it a mandatory training. It's very useful. It's very good for them to see real life data and pictures and all that stuff to understand what's going on and what needs to happen. And again, just giving them an update on any changes that happen throughout the program. So I wanted to go into a couple examples that I've run into recently and even in the past couple of years. So I have a couple case studies to kind of go through and discuss that I think will be pretty beneficial. And the first one I wanted to talk about was P-listed waste for small quantity generators. So my example, selfishly, is Massachusetts, because that's where I'm located. And it was a facility that was registered as a small quantity generator, and the issues will follow. So a hospital that had a pretty outdated program and hadn't been inspected in years. In this case, for Massachusetts, it's the DEP, the Department of Environmental Protection. They hadn't been inspected in years. They had a program. The program wasn't being kept up with. They didn't have a vendor on site to help manage the program, and it got pretty gnarly in some cases as far as how things were being collected. And then when the DEP walked in, the first thing they're going to ask, and truth be told, right now is a big subject, big topic for DEP inspectors going into small to mid-sized hospitals, is how much P-listed are you generating and how is it being tracked? In this case, there was a question mark on both fronts. So not only did they not know how much P-listed waste they were generating, but they weren't tracking any of it at all. So when they came in, they had a container that, again, was outdated. So they had everything going into one container: P-list material, U-listed material, characteristic material, and they're all going into the same container, but not really outlining how much P-listed waste was going in there. So when it was going onto a manifest, they had it listed as P-listed waste with the P codes on the manifest at X amount of pounds. In this case, it was well over 100 pounds. They had no tracking method to tell how much P-listed waste was in there. So, the issue that they bumped into was how much P-listed waste is being tracked. They didn't know, and how is P-listed material getting tracked? And again, they didn't know. So another thing that the DEP actually pointed out in this case was the fact that the weight that they were generating P-listed material was LQG amounts. And they really weren't, but they didn't really have a means of tracking whether or not they were or not. And so, something very similar happened in this scenario with a very small quantity generator that we did work with. They were actually listed as a very small quantity generator. However, on their formulary, they specifically had outlined nicotine and coumadin that they were generating, and I think it might have been actually physostigmine on there as well, and listed as a very small quantity generator, where in mass, very small quantity generators cannot generate any P-listed material. So right off the bat, they could tell that they were going over their regulatory limits. The profile that they had made up specifically had noted on their P-listed waste. So another thing, again, another small example of making sure that you understand your generator status and making sure that you're tracking that waste that's going out to make sure you're staying within those limits. Another example is actually geared towards large quantity generators. Who at a program management standpoint, it's not as hard because you can generate as much as you want from this stuff. So literally everything, you can generate as much waste as you need to as far as P-list material goes. But in most cases with large quantity generators, there are typically offsites associated with those large quantity generators, which is something that, again, are often forgotten, often not maintained. So again, just a lesson for large quantity generators, making sure that the offsites that you're managing are appropriately registered as a generator, but also understanding what they're actually generating there. And in a lot of cases, they'll use a blanket approval from the main hospital and use it amongst all the offsites, which again could lead into some issues if you're generating P-listed waste on the main site and not on the offsites. So another thing just to keep in mind, once you get the program in place, you're not off the hook. It's actually the whole maintaining and understanding generator statuses, understanding P-listed quantities, and all that good stuff. But my next case study actually relates right to this. Is exactly that first example that I gave was a client that hadn't reassessed their program in a long time, obviously, because they were still doing things that I wouldn't say wrong, but not appropriately. They had a pharmaceutical waste program in place, which is a good and it's a start, but they weren't maintaining it. And so it just, again, stresses the importance of reviewing and reevaluating your program on an annual basis to make sure that you are staying within those staying within the regulatory, staying compliant through in the regulations, but also making sure that your staff is well trained and equipped to manage these programs. So again, I just wanted to stress that, the importance of that annual reevaluation. So that's all I had for the case study portion. I did want to address something that is coming up that is still just proposed in Subpart P. I'm not going to go into detail, but I just wanted to let everybody know that we are working internally here to come up with a webinar that that's going to be taking place on October 28th, and it's really going to, you know, as the healthcare team, we're going to be working together to put a good informal, informational webinar together to really get you into the down and dirty of what Subpart P is all about, and again, just to keep in mind that it is still, you know, a proposed change, but you know, it's something that could come to light here in the future. So please stay tuned. It should be very helpful. It's very insightful, and let us know again if you have any questions on that front as well. So, but for the most part, I just wanted to kind of run over some potential action items that you could take after this training. And really, if there are 4 things to take away from this training, what would they be? So really, the things that I want to stress is identifying roles and responsibilities. Whose responsibility will it be to complete assessments of this program? How will you go about it? Who's going to be the one that, on an annual basis, is going to be looking at this stuff? And just to be clear, one thing I wanted to note is an annual basis, reviewing your program on an annual basis should be the minimum. Because again, that formulary is constantly changing. So making sure you identify who that person's going to be and who ultimately is going to manage that program and who's going to be responsible for reviewing it. Tracking generator status consistency. Who and how will this be tracked? Making sure that you're staying within your regulatory limits. We covered it a bunch. Getting end users involved right at the beginning. I wanted to talk about that. I actually skipped over that. My apologies. But get your end users involved right at the beginning. Get their buy-in, get their buy-in to the process, get their insight, get their concerns. Let them feel involved and let them feel they're a part of the process of getting everything going. And ultimately, that's going to help you with buy-in when the program's actually in play. And then again, reviewing your program on an annual basis, as I mentioned numerous times. But really, that's everything that I had. At this point, I think we can open it up for questions.
Sure, Dennis. So thanks for the presentation. That was very informative. And we do have a few questions kind of streaming in at this time.
Okay.
So we will open up the floor, like you said, and welcome any questions. We've got about 15 minutes here. So I do encourage you, if you have a question for Dennis, to go ahead and type it into the questions box, and he's here to respond. So Dennis, let's start with a question that gets back to the waste streams you talked about. And someone just wants some more insight on what others are typically doing with these various waste streams, such as narcotics and NIOSH-listed waste. I mean, what tends to happen?
So it can vary from hospital to hospital. So the example I'll give, so I'll start with non-hazardous waste. So again, it varies depending on what kind of hospital you are. If you're a large quantity generator, it makes sense for the ease of the program is to just collect it all in one container with the hazardous waste, because you're not under any restrictions, but also you have to keep your budget in mind. So if you are a large quantity and you're under a budget, you have to make sure you're separating. But more often than not, for large quantity generators, it's being lumped in all together. For narcotic waste, it varies quite a bit. So there's some hospitals that are ahead of the curve, some that are not. So I think normal, typical practice, and it comes from years of practice, is draining narcotics down the sink is not uncommon. Wasting narcotics in a pharmaceutical waste container at this point happens. So I think that's one of the bigger topics that have come up very recently with us is how do I get rid of this narcotic waste? How do I manage these narcotic wastes? And there are various ways of doing it. And that, in some cases there are containers that you can put on the wall and it has a substance in it that can essentially ensure that it's not recoverable right on the spot, and it can be disposed of that way. But there are other methods of doing it, and but most typically right now it's not really clear on how narcotic waste is getting disposed of, other than whatever waste outlet they have, whether it's the sink, sharps bin, pharmaceutical waste bin, or any various other methods of getting rid of this stuff. And then NIOSH is pretty common too. I'd say more often than not it's not getting collected as hazardous waste, and more often than not hazardous waste, as non-hazardous waste rather, just because hospitals are concerned with generator status, hospitals are concerned with budget concerns, as I think all hospitals are concerned of right now. So there's various ways of managing these wastes. I can go into more detail if anybody has any further questions on it. Again, I'm going to shoot out my contact information on this next slide, so if you want to write it down and shoot me an email or anything like that, I can certainly address those and what options there are.
Great. And Dennis, you went into detail about container sampling, and we got some comments in regards to the pie graph and the data that you shared.
Yeah.
So really interesting, and I guess we want to know, what should that graph look like? What's typical? I guess that was one of those scenarios. Maybe that is typical, but I'm not sure if it's one of those worst case scenarios. And how should those percentages really look in an ideal program?
So truthfully, and I can kind of scoot back to that. I'm going to scoot right back to that slide. Truthfully, that's a pretty good setup they have going on. And they know their hazardous waste is being collected. They know that their non-hazardous waste is being collected. I'd say 20 to 25% of the stuff is really non-compliant, which in history and some of the experience that I've seen, that graph right there is pretty good. It's when you start seeing the reds, the blues, and the oranges creep over to a higher percentage is what you don't want to see. Now, in some cases, you're not going to want to see non-hazardous waste being that. So this is a container that was supposed to be collecting hazardous waste. And obviously, the lion's share of that container was non-hazardous waste. So really, it should look like how you want it to look like, and understand that there is going to be some variance as to what shouldn't be going in there. And again, this is stuff that you can use to re-educate. And if this was something that a hospital that hasn't visited something like this in a while, my guess is that those orange, blues, and the red, blues, and oranges, the universal waste, the biological waste, the municipal trash, the stuff that really shouldn't be going in there, is probably bigger than that. So in honesty, I was shocked to see that this one was as low as it was. So I hope that answers your questions. Again, if you have any more questions and have any more, if you want any more insight on that, I'm more than happy to field questions.
Sure, I think it does. And Kenneth might want some clarifying information really on what can be done to help staff on the unit identify hazardous versus non-hazardous waste, which could help with that process you just outlined.
Yes, the most typical thing that happens is signage, using the appropriate signage and really outlining what's supposed to be going into those containers. And so if you have a satellite accumulation area, it's hard to ensure that a nurse is going to understand what each medication is and how it's regulated, whether it's non-hazardous or hazardous. My suggestion is keeping signage and labeling out, but also creating like a flow chart sheet. And in some cases, they do have that on what specific waste streams are supposed to go where, and really breaking it down to each waste stream, like non-hazardous, hazardous, biological, sharps, and really allowing them to see like an actual chart of how all these things are being disposed of. But really, if you're collecting hazardous waste, and you're collecting it separate from everything else, is making sure you have something for there to use as a guide and as a document, as a resource to understand what needs to go into each container.
Dennis, another question, thanks for that, is in regards to off-site facilities and the processes in place there. So in your experience, how have you seen hospitals manage their off-site facilities?
So some in good, some bad. So it's one of those things where you have this, and typically it's large quantity generators that have most of the offsites, but a lot of time spent is on that large quantity generator to make sure that's a compliantly run program, which unintentionally leaves some question marks around those offsites. So the biggest key is making sure and going through that, just that even the initial stages of setting up a program, and making sure that they're properly registered and they're properly registered, they have the proper formulary characterized. So again, I'll go back to the scenario where large quantity generators have a blanket formulary that covers all of their offsites and the main site, which again can get you in trouble in the sense that depending on what you're collecting only on the main campus is ultimately being shown on the offsites. So making sure that you have having site-specific formularies outlining what exactly is being generated, but what possibly could be generated, and then making sure that your generator status is adjusted towards that. And again, what I'm going to use the mass example again, and we find that when we go in and we observe a lot of the offsites for large quantity generators, is that most of them, based on the amount of what they're generating, is very small quantity generator amounts. And that's typically how they're registered. However, they'll have nicotine or coumadin on the actual formulary. So right at those are the type of things that the DEP is targeting, or those scenarios where very small quantity generators, or even small quantity generators, or conditionally exempt small quantity generators, are generating more than what they should be generating. Another thing that I have seen helpful in a success story that we've had from the offsites is putting a single person in charge. Not necessarily the person that's managing the large site, but having another person manage those offsites and make sure that they're staying within their regulatory requirements. And kind of putting like a key person to make sure that they're running appropriately.
Great, thanks. That's good advice, Dennis. I think that'll be useful to those that were wondering. So we'll take a couple more questions, and if we don't get to your question today, know that we will follow up very soon with an answer, so we won't be ignoring any questions that come in. But you spent a lot of time talking about the importance of performing annual reviews at a minimum. So are there any circumstances where it makes sense to do this on a more frequent basis?
Yeah, I mean, it's hard. I mean, a lot of pharmacy directors are going to know better than me on how often that formulary is going to change. In an ideal world, every single time a medication gets added to a formulary, the program's being evaluated, and they're making sure that it's hazardous or non-hazardous, and then updating the profile. But it's pretty understanding that that's not really sustainable, and it's really hard to keep up with. So I mean, that's really the only time. I mean, in reality, anytime something gets added to the formulary, dropped from the formulary, it should be reviewed, and going again in that same scenario is it can be pretty cumbersome. So my suggestion would be annually, making sure that every year you're getting an up-to-date current copy of that formulary and taking a look at to see what was added and what wasn't added. In some cases, we found that they have the ability to track just the items. They'll have the formulary, but on a separate tab within an Excel sheet, work document, they'll have another form that everything that had been added or dropped in the past year. So again, for all the same reasons we discussed earlier in the webinar, it's it's one thing that can affect many things down the line, and could potentially put you in some regulatory burden.
Got it. So if you're doing this annually, you're in a good place, right? We're doing a good job.
Yeah, I would.
Yeah.
I give that a minimum because like that slide said before, the formulary could always be in a constant state of change depending on what's coming in and what's going out.
Right. Good. So finally, the last question deals with training. Again, you highlighted how crucial it is to have a training plan. So are there any programs or courses or providers you'd recommend that have worked well for clients that you've serviced?
So any program, can you repeat that, James? Sorry.
Yeah, training programs, internal or external, when it comes to this hazardous waste program management, and plan development. So can that be done internally, or are there any external sort of sources or courses that you'd recommend?
So really everything should be, it's easy to, as far as the trainings on an ongoing and annual basis for your staff, it really should be site specific. So it can be done internally. There's vendors that do it. Triumvirate will help do it. It's something that it should, like I said, should be very site specific, because every site's different in what they're generating and what, and it's very different. Sometimes the culture within hospitals could differ from the other. So the type of trainings that you're giving, whether it's going to be like a formal or informal in-service type training, the hospital's going to know that best rather than going to like a generic pharmacy waste awareness type training, where it should be really site-specific training, and having the people that really understand the program give those trainings as well.
Great. Well, thanks, Dennis. And I think we'll wrap it up there. We're just about at the top of the hour, so great job. Enjoyed the presentation. And if there are any other questions, I know Dennis has his contact information on the next slide. Dennis, do you have anything else before we conclude here today?
Yeah, no, just to reinforce what James is saying, if there are any questions, I'm available by any communication, whether it's email or a phone call. So if you have any questions, by all means, more than happy to help. So, but that's all I really have.
Awesome. Well, thank you, everyone. We want to thank you for participating, for listening. And again, expect an email tomorrow. We'll send you this presentation. You'll have access to the slides. You'll get the recording, and also a short survey. So let us know what you thought, and share your feedback so we can take that information and use it when planning future webinars, including the one at the end of next month, where we'll be talking about that new proposal as far as pharmaceutical hazardous waste. So check out our website, and we look forward to seeing you next time. Have a great day.
Thanks, everyone.